So, you're British, right? Yeah,
That's,
that's what you said in your
yeah.
fun fact about me.
That's how you want to
Yeah,
start?
that's how I want to start this. Basically,
Yeah.
I'm just it's colonialism. I want to just I got to settle the score on that, but not really. Did
Yeah.
you hear the latest news that came out last weekend from the UK?
I don't think so.
Basically, the Prime Minister Sunak, he announced that starting next year,
Yeah.
the smoking age is going to go up by 1 year every single year. So a 14-year-old right now will never in their lifetime be eligible to legally buy a cigarette in the United Kingdom.
Wait, what is it? So the age is how much?
So right now the age is I don't know, 18, 19, whatever it is
Yeah.
right now.
Yeah.
But let's say you're born in 2023 and you
Yeah.
turn 18 years from now. Whenever you turn 18, the voting age, the smoking legal smoking age would have risen so much that you would never be eligible to legally buy a cigarette, and it's going to continue to go up until no one in the population is going to be legally eligible to buy a cigarette.
Yeah. Yeah. Yeah.
That's
That's pretty funny. That's pretty,
yeah.
Why am I missing something? But why don't they just ban it outright?
A good question. And the reason for that is if someone right now, has a smoking habit,
Yeah.
odds are they don't want other people to pick it up, but they can't give it up
They
either.
can't give
They've
it up,
tried,
yeah.
And I think the reasoning behind that is that it's sort of inhumane to ask of someone who is, who is habitually smoking
Just
to
to
suddenly
stop,
stop right away.
And then just arrest them if they
Yeah.
yeah, that just makes sense.
So for that reason, you and I, since we're above 18 right now,
Yeah.
we'll always be eligible for the rest of our lives to
To
buy
smoke in the
cigarettes.
UK?
Yeah,
Okay.
smoke in the UK. Yeah, we want to smoke it up there. Yeah.
Okay.
So we will always be eligible, but this next generation of people coming in will just never be able to buy an e-cigarette, a vape, I think, anything
Yeah,
like that.
yeah.
Now, I should mention the UK isn't the first country in the world to do this. This is a New Zealand model.
Mm-hmm.
They did it first, and I think for them it kicks in 2027. So we haven't seen any data from how this helps or if this eliminates smoking at all.
Yeah.
But I would suspect that it's a step in the right direction.
Yeah. Yeah. And I wonder if Canada is gonna follow suit.
Yeah. Yeah, it's an interesting one because it's a conservative government that is in power in the United Kingdom right now, and conservatives usually are against more regulation and more stuff like that. But I think this is one of those things that there's pretty broad support for a piece of legislation like this.
Yeah. They're also very against drugs, so usually.
Yeah. I don't know what it's like there. You know better, obviously.
Well, I don't know. I was 14 when I don't know how old was I? It was 2014. I was 11 when I moved.
Wow.
Yeah. How's the tea?
That's good.
Yeah.
Mm-hmm.
I was 11 when I moved, so I don't know anything about I don't even know who's the prime minister at the time was Gordon Cameron.
Oh, heard of the guy.
Yeah. I just
I know nothing about
I
it.
know nothing about him either. I just know his
Yeah.
name because he was the prime minister when I lived there.
Yeah.
But
Barack name dropped him in his book quite a bit.
oh really?
Yeah.
In a good way or bad?
In a good way, I think.
Okay.
Yeah. You'd have to ask him.
Yeah. Okay. Or read his book.
Yeah. And next time we'll meet him, we'll just ask.
Yeah. Next time. But yeah. Yeah. No. The UK is a nice place. The weird thing is that everyone smokes and drinks there. At 16 or 17 years old.
Yeah.
Yeah. It's.
You're just gonna stereotype an entire country. But I know it's a larger part of the culture there.
It is a big part of the culture. People at 16, 17, they start drinking.
Yeah. It is there's the European model of drinking, which is very different. It's you get introduced to it in pubs and where you're along with family and friends, and it's more sort of it's a gradual pickup.
It's a gradual, and it's less here it's more if you. What I found is if you go to a club or something with your friends, and it is a very different environment. But yeah, I remember I was 14. No, I was not 14. I was 11.
Mm-hmm.
I keep thinking because I moved in 2014, but I was 11, and one of my friends I think turned to the legal drinking age at the time, and he was not that much older than me, or that's what it seemed like.
Something I think the legal age still is 18 from what I recall in this.
Mm-hmm.
There, but there's some kind of variation. If you're with a parental guardian, you're allowed to do it earlier.
have a feeling he was. I don't remember. Maybe I'm remembering it wrong because I was 11, but he just felt very close to me in terms of my age. I was like, damn, I'm that close to being able to drink, and I was 11. So yeah, it just feels like you can start very young there, compared to here.
I don't know if that's like particularly a good or bad thing. I haven't like looked up the data on it, but I can tell you from my like anecdotal experience. I work as an RA, so I see more drunk teenagers than almost anyone else.
Yeah.
I mean, by teenagers, I mean people. I'm a teenager too, but
yeah.
People who are like a year or two younger than I am.
Yeah.
And because of the fact that drinking isn't that big a part of a culture, isn't as big of a part of the culture here in Canada, what I see is like people get that first, chance, first little lick of freedom to kind of go off and get a drink with their friends, and they don't know their limits, so they end up going too fast, too far, and it doesn't end well sometimes.
Yeah. But I have a feeling we tend to focus on the times when it doesn't end well, and a lot of times it's just fun.
Yeah, sure.
Yeah.
Yeah.
But so again, I don't think it's necessarily a bad thing unless like you go too far. But then stuff we learn in our neuroscience classes, for example, I was reading some papers, I think at the start of the year, about how adolescent drinking and adolescent marijuana prevents myelination of the prefrontal cortex as they're developing.
Wow.
And from what we know, the prefrontal cortex is like very active in like executive function.
Right.
So preventing that myelination slows the propagation of the signals.
Well, we need to like spend another minute on this. This is just a bombshell. Yeah. I didn't know this. What I did know was that cannabis use under the age of like 25.
Yeah.
Right now our brains are still super plastic because we're under 25. Yeah. As we age, no, I should define plastic as plastic just means that it's malleable. We can form new connections. We can learn new things. We can learn how to drive. This is an age where a lot of people pick up new music, instruments, skills, stuff like that. That's the age we're still in. One of the effects of cannabinoid use or cannabis use in general at this age is that it like reduces that hippocampal plasticity, and the hippocampus is super implicated in memory formation and stuff like that. Yeah. What I did not know is what you just told me.
Yeah.
What's the implication of the prefrontal cortex?
Well, it's involved in executive function. So
what exactly does like executive function?
For example,
mean?
That's a good point. For example, like things like problem solving, decision making, inhibitions. Alcohol it kind of messes up your executive like inhibition, so you do things that you normally wouldn't do. So
whatever's keeping me from acting on my intrusive thoughts right now is like that prefrontal cortex. And when you talk about myelination,
but actually, I guess I should explain that. I think I'm so used to I'm talking to you.
I know.
You're in neuroscience, so
So
let me step back a little.
Yeah.
Before I talk about myelination and all like the anatomy of it, there was a study that they did, and they found that it, I forget which. I shouldn't say if I don't remember exactly, but I think some.
What do you recall?
Problems. I think it was something around problem solving. Abilities are reduced, and because. So basically what happens in neurons is that you have a neuron is just a piece of is a cell type that's found in your brain, and it has this really long part where signals are sent down called axons. And these axons are covered by these fatty substances called myelin. And basically these myelin, without getting into too much detail, are there to help signals that travel faster down your axons, right? And more effectively. So what happens when, and this myelination of your axons, so adding myelin to your axons, happens during development in many brain areas. So it's not fully formed.
Right.
So then what they found is that it actually prevents this myelination process if you have if you drink or
Wait, is it
weed.
alcohol and cannabis?
I
And
believe
or
the paper I read was about cannabis.
okay, so
Yeah.
like that's like two big implications for young people because I know in Canada now, I think cannabis has been legal for or decriminalized and legalized for a better part of like a decade now.
Yeah, and it's like anyone over 18, I think.
19.
19?
19 in this province. I think it's
Oh, yeah,
age
19.
of maturity.
Yeah.
Yeah. So I have a lot of people like within our friend circle who are who turn 18, turn 19, and it's you take your ID and you go to the weed store and you can basically get your hands on anything you want.
Yeah.
But I think one of the things we need to understand is like what is the long term impact of consuming cannabis at this age. We know it slows down plasticity, so you're less likely to learn new things.
Yeah.
Which at this point, like we just want to get our hands on as much plasticity as we can, so that we can.
Yeah, you were telling me that fact about music the other day.
Yeah.
That reminds me. Do you wanna...
Yeah, for sure. This actually comes to us from Malcolm Gladwell. He was talking about it as well on his podcast, but there's like this golden age when it comes to music taste.
Yeah.
I know we have very differing music tastes, so this is something that's why I brought it up. You're more into. I'll let you describe your music taste.
I'm into a lot of things, except probably the one that you like the most.
Okay, to be fair, let's just be clear here.
I like and the one you like is mainly country, right?
Country makes up like a substantial part of it, but it's just one part. It's like maybe like 15-20%.
Okay, but that is the part that I like the least about. Like that's the genre I probably like the least.
Yeah.
But there are aspects of it I enjoy. I think you played a song the other day that I enjoyed. So.
Yeah, same way with like rap.
Yeah.
I try to get into it. I'll do some hip hop. I dabble with like the more popular artists.
Yeah.
But you're like the one who's like trying to get me to like some of the more niche ones.
Yeah.
So yeah, like right now we're exploring music tastes. There's like this golden age, which just so happens to be 19.
Yeah.
Where the music that you like in that sort of range, that like late teen range, it sort of stops around your early 20s. The music we listen to right now is the music we'll like for the rest of our lives.
Yeah.
So that's why you see people like you ask them what kind of music is their favorite, they'll automatically just revert to whatever they listened to in their late teens.
Yeah,
And
so it kind of sticks with you, whatever you listen to now.
Exactly.
It's hard to basically like new music when in your like 40s. Or,
yeah. The hypothesis around that right now, leading one at least, is that music is sort of like, it's predictable variation.
Yeah.
If music were complete variation, it'd just be noise. Stuff that you wouldn't be able to predict at all and wouldn't enjoy as much. But music is patterns that you already understand, variation along those patterns that creates new music, and that's why we why we have there's not going to be a day where we've just had all the songs or all the melodies in the world.
Yeah. And that takes back to plasticity.
Yeah.
Where were we?
We were talking about cannabis and how it reduces plasticity. What I just learned is that not only does it reduce plasticity, it also prevents the prefrontal cortex, the area of your brain responsible for inhibition, for executive control, for all those things that make us, keep us from acting on some of those intrusive thoughts. All of those things, it sounds like cannabis has an impact on that as well, and it reduces sort of how effective that the development of the prefrontal cortex can be.
Yeah. Yeah.
Super cool. Yeah. I don't know what kind of markings are there on cannabinoid products right now. Do they come with a warning sign, or should they come with a warning sign that
sure
if you're under 25, this has a
greater
risk for you?
I don't think I have. I don't know. I've never bought it.
Yeah.
I've seen the packets. They have a red thing, but I haven't actually read what it says.
Yeah.
I have a feeling they probably don't tell. They don't specify
because this is research that is just coming out. Cannabis was legalized less than 10 years ago. We remember when it was. When that news came in, so we don't know. Then. We don't know what the large scale implication of this is going to be.
Yeah.
There is a researcher over at Western University that I listened to. I went to a talk, and he was over here at UBC, and he was talking about how their research is looking into the addictive effects of THC and CBD, the two most popular cannabinoid products on the market right now, and some of the variation we're seeing right now, based on what's what it says on the label versus what's actually in the package. Yeah, it's wild, and we're seeing in some cases underestimates of THC levels and overestimates of CBD levels. And I was talking to another friend of ours in neuroscience, and we spoke about how CBD is sort of part of the cannabinoid that gives it its like non-addictive property. I'm not sure what the exact mechanism of it is.
I forget. Someone was telling me about this. It yeah. What was it? Yeah, it's like somewhat of a what she was saying. It was somewhat of a safer form.
Mm-hmm.
But I don't really know how it works.
Yeah, and that's why like that lab over at Western University is looking into it, because CBD is something that's just infiltrated the culture so much in recent years. Like people give their pets CBD. People take it to go to bed. They'll, in some cases, like I've even like heard that people take it for stuff like Parkinson's or Alzheimer's or Huntington's, where not Alzheimer's, sorry, but neurological conditions that it allows them to like relieve symptoms for a little bit.
Yeah.
Speaking of using drugs to alleviate neurological conditions, we just learned this in our brain dysfunction class, but cocaine tends to be a great thing to help like normalize the on and off properties of some drugs that help with Parkinson's disease.
Yeah.
So do you want to explain how that works?
I don't think, did we learn how it
We
works?
learned a little bit about how if you take like a drug for Parkinson's, let's say like L-Dopa or something, it has these like on and off periods.
Oh, that, yeah. Okay, I thought you meant how the cocaine works.
Yeah, I don't know how that works either.
Yeah, like we learned, I think, that the efficacy of certain drugs can wear off sometimes, where you get like these on and off periods, and the on periods are times where those drugs have high efficacy and are like they seem to be working to reduce symptoms, and the off periods are when the symptoms reappear. And then I think what was said, that some patients with Parkinson's that were experiencing off symptoms when they were taking a particular drug called L-Dopa, they took cocaine, and it was a very potent way to reduce their symptoms during the off period.
Yeah.
Which is crazy.
Yeah.
Yeah. So.
Yeah. That it's interesting because we're talking about like hard drugs at this point, and like we talked about weed being legalized. Right now, sort of nationwide, we're seeing a decriminalization of, I think, self-use, like small doses or small quantities of hard drugs. That's a topic that's been contentious. A lot of people have very differing views on this, and they're very passionate about it, rightfully so. It is, something that takes out a large part of the population, and almost everyone knows someone who is living with addiction. So right now in Canada, we're seeing sort of large-scale decriminalization of small quantities of hard drugs. It started off right here in BC, where we saw, I think January was when we saw the legalization or decriminalization of small quantities. And we're not sure, I don't think we've seen the data yet on how that's changed mortality rates and addiction rates around town, but now it's sort of been nationalized, or about to be nationalized. What do you think of that?
It's hard for me to say too much about it, because I don't know too much about it, but like it's especially like a big thing to talk about if you live in Vancouver, because the whole thing with the downtown east side area, and I was there the other day, and it's really hard to walk past. It's like, it's sad, and I don't know. I talk with a lot of those people. I work with a lot of the people that are there, and I don't know. It's sad to see people live in that situation, and a lot of this is anecdotal, which has some value in my opinion. So, but it's not, obviously there's no statistics associated with what I'm saying, but I walk past and I see a lot of those, I don't know what they're called, the bands that you use to isolate a vein, or right?
A pressure band.
Yeah, exactly. And then a lot of like those, like the pipes that you use for some hard drugs, and just walking down the area makes me sad to think that it's just so common to see those just multiple of those lying around in the street, and it's just sad in Vancouver, and for those reasons, for those reasons, I don't know how I feel about it.
It's normal to be like, split on an issue like this. There's no easy answer here. Addiction is something that I think humanity itself has been trying to solve since the beginning of time. I think we have moved to a place where we're dealing with it with a lot more empathy. But like you said, I've been walking downtown East Side to like catch a bus or something since like I started like just going off on my own since like grade 9 or something. Yeah. And it's always been like a scary area to walk through, or even if you're driving through it, it's like the speed limit's down to 30 so that people who are intoxicated, inebriated, and they're just like walking across the street.
You see it all the time there,
Yeah, that's commonplace, and that's why you like go slow. You make sure you're not hurting anyone. There's ambulances on standby. There's usually RCMP presence or VPD presence in the area.
They're everywhere in there.
Yeah, that makes the situation slightly safer. But then again, like it's not it's a band-aid to an issue that spans much larger than that. Yeah,
for sure. I think last year there was this one VPD initiative. I don't know if you saw it, but because there's tents there, right?
Right.
They kind of one day they walked through and they were like, enough is enough. We're gonna get rid of all the tents.
Yeah.
Do you remember that?
That directive I think came from like the city of Vancouver.
Yeah, and now the tents are back. So all it did is get rid of people's shelter for a bit. And I think the idea was that the tents are not safe.
Yeah.
Anything could be happening in those tents.
Of course.
It could be dangerous. But where are they gonna go?
That's true.
So yeah, a lot of it does feel like a band-aid and like just attacking the symptoms rather than the cause. But again, it's really hard to know the cause of something so deeply rooted.
It's clearly multifaceted, and it's not going to be solved overnight with just like kicking people out of their tents.
Yeah.
I think there's more to be done there, but something that I really want to talk about, and what this reminds me is, there's this book called Hungry Ghosts.
Okay.
And it's all about addiction, and it's written by Dr. Gabor Mate, who is a family physician. I think he's like nearing 80 now, if not already 80, who has been working in the downtown East Side his entire life, or his entire professional career at least. And he has just some very nuanced insights on the matter of addiction and how it perpetrates. And one of the assertions of the book is this notion that the importance of early life events. So we talked about genetics, and there's clearly like a genetic component to addictions that's hereditary. But then there's this epigenetic component, and epigenetics, just to clarify, is like, it literally means above genetics or on top of genetics. And it's like this methylation and other stuff that happens in sort of those, from like pregnancy into like the first few years of life.
Yeah.
And
I think beyond that.
Beyond that, probably.
Probably like during development.
Yeah. All the way through like adolescence until you hit puberty, maybe even through some of that.
Yeah.
But basically the point in the book was that people who unfortunately did not receive the best care growing up, or like in that early stage when our brains are really very, very plastic, they tend to struggle. They tend to struggle with, anxiety, depression, stuff like that. And for them, sometimes taking these drugs is the only way they can get like a transient relief from those symptoms. Yeah. And we're fortunate enough that we didn't, we don't have to rely on those kind of substances to function. But there's a lot of people that do.
And a lot of that is also what makes me think that decriminalizing these hard drugs won't really change much, right? The only things that it may change is, it won't change much because again, it's taking these hard drugs is again like a symptom of a larger issue.
Yeah.
But yeah, it is sad. But yeah, sorry, you were saying.
Basically, just like continuing along that, like it's that stress. Like think about it this way: when you're born, you have no way to deal with stress. Stress is something that if your body's stressed, a child has no way to deal with it. They don't have the mechanisms to do it. But one of the things that that's where parental guardians and family and stuff like that come in. They can, like a child who is never picked up, will basically stress itself to death. That's something that we've recorded. A child who has every other need met, so that's like nutrition, cleanliness, hygiene, all of that, but is never picked up.
Yeah,
that's a child that will literally stress itself to death. when I read that, I was just like shook. Yeah.
That is kind of crazy. Yeah.
It is. And then as you like develop and you're like calmed down by external factors, whether that's your parents picking you up or something else that calms you down, eventually you develop the mechanisms to just calm yourself down when a situation gets stressful until, if you're an adult who's functionally normal, if there is such a thing, a simple deep breath might be something that calms you down.
Yeah.
But for a lot of people, like substances are the only way they can sort of get that transient relief, and that's why they sort of lean into these addictions. And a lot of these people that he wrote about in the downtown East Side, patients of his, had instances of trauma very early on in their life, whether it was domestic abuse or sexual assault or something like that.
Yeah. There's an organization in the downtown East Side, the Vancouver Street Soccer League, which I have worked with, that looks into helping these people through other means, like through other means of escape other than like these hard drugs.
Recreation.
Through recreation, through soccer. And they're currently, I think it was started actually by the UBC psychology program.
Wow.
Someone named Dr. Alan Bates. I don't know if you've heard of him.
I've heard that name before. Yeah.
He's a professor in psychology, I believe.
Wow.
And he started it. I think this is why I haven't actually met him yet, but he started it to investigate the role of sports and recreation in helping people who've gone through these like early life events, right? And it's helped a lot of people over it's been there for the last 10 years, and people describe it as like their second family.
Wow. That's beautiful.
Yeah. So yeah, I think investing in other ways, rather than investing in taking tents off of streets, investing in other ways to give people in the downtown East Side an escape is what's important. Yeah.
The downtown East Side settlement, it's not a permanent solution, of course, but like creating more treatment centers, that's something that the government could invest in, whether it's provincially or federally. More treatment centers, more spots to care for them, more doctors. That's something that might actually help alleviate the situation. Then housing for these people, affordable housing near those care centers where they can go temporarily live there until they're fully recovered, and then eventually integrate back into society and continue their lives.
Yeah, there's layers to that, like to fixing the problem, and I think the Street Soccer League kind of focuses on like the integrating part. But there's so much before that, like how people can't just like people there. Not everyone can just go up and play soccer. They're not in the right mind state.
The withdrawal symptoms alone, if they were to stop immediately, would be just soul crushing.
Yeah. You kind of need someone to mediate that that tapering. And treatment center. Increase in investments in treatment centers would be a way. It just again it goes back to the fact that it's just such a big issue that funding for anything like this is insane. And the thing is, like, a lot of when you ask about a cause, a lot of it's hard because a lot of the people, like the homeless population in Canada, live in Vancouver. They migrate to Vancouver because it's warm in Vancouver. They can't live in Calgary. They can't live in Toronto because it's too cold. So again, it's like a lot of the cause isn't just from Vancouver. It just happens to be that everyone goes to Vancouver. So it makes it even harder to identify a cause and fix that solution. But fix that problem. But there's a lot of layers to it, and it is sad. But the book you talk about sounds interesting.
Check it out. Hungry Ghosts by Dr. Gabor Mate.
What is that name?
Hungry Ghosts basically talks about that, like, I think it's a metaphor for that sort of feeling that people get the urge to go for another drug. And he very candidly talks about his own addictions in that book as well, and how he struggled with it and worked through them. So it's a very candid book, and Hungry Ghost basically just means like that hunger or that desire to go for another dose of the drug, or whatever activity it is that happens to be their their
Yeah.
addiction. But I want to go back to something you mentioned, which was like more funding is needed.
Yeah.
That's something that I think Health Frontiers, we've been very much focused on
Yeah.
advocating for more funding, whether that's within the university system, provincially, federally. We're trying to get more funding for healthcare.
Yeah. Yeah.
There's a need for more funding in this country right now, and how the system itself is like under more pressure right now than you can possibly imagine. Specialist wait times are 6 months to a year in most cases. Surgery wait times are like 9 to 12 months.
Yeah. Yeah. It's terrible. It's terrible.
How are we solving it?
We're
How are we
doing
doing
it
our part to solve it?
There's only so much one can do. It's actually insane the amount of money that's involved with things like this. But yeah, we're working on our part through smaller initiatives that we won't mention right now until they're done. But yeah, the changes that go into something as big as a healthcare system have to be stemmed from politics.
Unfortunately, in Canada, that is the way the system's structured.
Yeah.
We have a single payer system, what it's called, where all taxpayers, pay their taxes, but the government is the only public insurer of primary care services. We have private care for certain things like psychiatry and dental and vision and and pharmacare, stuff like that, and dental, but that's not something that is for primary care. And here's the thing: the Canada Health Act basically outlaws a private insurer from functioning in Canada.
Yeah, and I feel like there's good and bad things to things like that, and I think we're getting at the bad part, which is that the decider of who gets funding is all centralized into the government, right?
Well, it's sort of decentralized in a way where you have 50% funding coming from the federal government and then 50% from the provinces, and then the provinces sort of get to decide which health authority gets how much money. So there's a lot of layers here to like how that funding works and how it gets somewhere.
Yeah, yeah. But there could be more.
A lot more could be done.
Yeah. And but yeah, there's good things to it as well.
Of course. I think we have some of the most equitable access to care in the world right now. But at the same time, that equity just means that everyone's having to wait a really, really long time before they get the care that they deserve.
Yeah, yeah.
So I've had a lot of discussions with people, healthcare staff members, patients, families who have struggled with getting care, and there seems to be a hunger for change. A lot of people still care about the universal healthcare system and want it to continue to function so that everyone has access to care, and that's a big thing that I'm passionate about as well. But then again, the way the system stands right now is not working for anyone.
Yeah.
I know so many people who are having to leave the country and go elsewhere to get the care they deserve in a private system and pay more out of pocket.
Yeah, there was that one thing about it was here in Vancouver, something about people had to go to Seattle.
I don't recall exactly what you're talking about.
But there was something where we had to offload the burden on our system to the one in the U.S. It was something like that, and it was here, but I forget.
I'm not surprised by that.
Yeah.
We are at maximum capacity. A hospital that I used to volunteer at, I've heard from someone who's still there, that the hospital right now, we're nearly 3-4 years out of the pandemic, it is still functioning at 120% bed capacity.
Really?
Yeah, and that's I wish that was the exception. That's well below the normal, actually.
Yeah.
And every single health authority, every single system is just under so much pressure. And we could go into the stats about how many people right here in this province don't have a family doctor or don't have, someone to look out for them. And that's one of the reasons why we started Health Frontiers.
Yeah. There's a lot of stories of family doctors retiring and just losing the family doctor, and people are confused and lost. And people want change because of that.
The other thing that comes out of this crisis is people rely more on the emergency room. So they go to the emergency room when they don't really have an emergent situation, which is fair because how else would you get quick care?
You don't have a primary care doctor.
Exactly.
So where else do you go?
what that leads to is insanely long wait times when it comes to the emergency
people
room.
who actually have an emergency don't get attended to on time.
Exactly.
Yeah.
You know, it's like, but that's just one of the issues. The other problem is there's so many people who have to wait. I'll be honest. In some cases, upwards of 10 hours in emergency rooms around the country.
Yeah, I've personally been in emergency rooms where people have to wait 12 hours, and it's in the middle of the night. This was in Calgary, so it's cold as hell outside.
And they're in a waiting room at this point, or are they waiting outside? It's sort of an in between.
There's multiple layers to the emergency department where I was at, but from the time you walk in to the time you see a doctor,
that's 12 hours.
10 to 12 hours. Not the time you leave, to the time you see a doctor.
Wow.
And that was you don't see that too often. Usually it's around 6 or 7, which is still terrible.
Yeah.
But yeah, it gets really bad, and it's till the time you see a doctor, and that could then there could be like, oh, the doctor orders some imaging, and that's and you don't even start to think about how much longer that would take.
Of course.
Yeah.
Here's a statistic for you. There's this thing called the Leave Without Being Seen, LWBS.
Yeah.
And it's a statistic that basically measures how many people walked into the ER with a condition or an issue of some sort, and then left without being seen by a doctor because of how atrocious the wait time was.
Yeah.
That number was somewhere around 300K pre-pandemic, so like 2019, 2020. We're looking at 300,000 people leaving the ER without being seen.
Like in the
across
country?
Canada, yeah,
Like
nationwide
per year.
per year.
Okay.
That's 300,000 back then. In the span of these last 3-4 years, that number has shot up to 1.3 million
per year.
That's correct.
Yeah.
That's 1.3 million Canadians who are leaving without being seen because of how long the wait time was.
It's kind of ironic too. Like during a pandemic, you would expect that people would want to be seen by a doctor.
Yeah.
With the increased illness, but yeah, it is terrible.
Yeah. That's one of the things that funding can combat. Funding means, what exactly does more funding mean? It means hiring more physicians, more care staff, more nurses, more beds, more infrastructure. All of that, supports a system that can function properly. But the problem is, even if we start today, building more infrastructure, training more students, hiring more people, it'll be like another decade before we actually come out of this problem. And I don't see a clear solution to how we solve it, in this time period when people are actually struggling and people are hurting and in pain. Yeah.
And honestly, there might not be a solution. Things like this on such a large scale often don't change so quickly, and I don't know if it's fair to expect it to change.
I know, but then again, like, I can't get cynical or give up hope that the situation can change, within a short time span. Because the people, there's someone who's waiting for a hip surgery right now and has been told to wait like 2.5 years. Their only solution might be to like use more opiates so that they can function, not be constantly in pain. So for someone like that, saying that a decade-long solution, that kind of a timeline simply doesn't work for them. We are in the middle of a healthcare crisis in this country right now, and it's so hard to see because you don't realize just how bad it is until you're in a position where you're having to access care.
Yeah. Some part of me just finds it so hard to believe that a major scale change is going to happen. Yeah, and it you talk about this a lot, like hope.
Yeah.
And what does it mean to have hope? And in this country, it feels right now as if it's hard when things just keep getting worse in terms of healthcare, and the wait times keep getting longer, and it's just unfortunate that all this intersected with COVID as well to make it even worse. But yeah, a lot of and that's not where the problems in Canada end too. There's things like housing.
Yeah.
So there's a lot of different things to focus on and spend money on as well that the government wants to spend money on.
Yeah.
So again, with so many different issues to focus on, and with healthcare being such an expensive one, it's hard to see. And it's not like you could spend. You have to spend a lot of money to start seeing change. You can't. Like little bits won't do much. So it's all or nothing.
Let's talk about hope, though.
Yeah.
You brought that up, and why I'm still hopeful that the system itself will either improve or change in a way that will, lead to better outcomes for patients and care staff. Because truly, like the people who are caring for us also want to see this change.
Yeah.
They just have their hands tied because of a system
that they can do.
Yeah. And nothing against them, because they're truly trying their best and working as efficiently as possible to deliver care. But what gives me hope is when I look at the track record of our nation. There was a time where we did not have a public healthcare system, and it was grassroots advocacy from people like you and me who eventually got into Parliament and figured out how we could get to a place where everyone in Canada has insurance. Without their efforts, we wouldn't have this healthcare system that insures every single person in this nation.
What was it? Douglas?
Tommy Douglas.
Tommy Douglas. Yeah.
He was one of the big advocates for public healthcare, but then again, it wasn't his party, but a different party that was in government that created the bill and eventually signed it into law. So it was a lot of parties coming together to make sure that this happened. So if they can do it then when, there is no precedent for a system like this in Canada, I think we can do our part to improve the situation a little bit. And the other thing about hope is I was raised by a person, Barack Obama, seeing him on TV every weekend. We're kids, during his presidency, and hope was his entire platform. He was the hope guy. That's something that's, I feel like, ingrained into me, and that's why I feel like I owe it to other people in this country and myself to not give up hope and not give in to cynicism, because it's too easy to do that.
Yeah.
We got to keep trying, even if it's challenging, even if the odds seem insurmountable.
Yeah, that's nice, isn't it? The like having like someone like that you grew up with that kind of instilled that in you is nice. Yeah.
Let's talk about something else that's super contentious right now in Canadian healthcare, and that's the issue of medical assistance in dying.
Yeah.
It's this notion that someone who wants to end their life can do so with a proper legal process and work with the care team to end their life on their own terms.
Yeah, it's just to clarify, where exactly is it legal now? I believe in Canada.
So it is a federal thing. So once it's passed, it has been passed for a while now. It is sort of legalized nationwide. There are a lot of provincial guidelines around it. I'm not sure exactly how the law works there.
Yeah.
But what I do know is right now Quebec is one of those provinces that is seeing the most number of cases per capita, at least, in terms of people contesting the system for what it's doing. There's very strong voices on both sides. People who really want it to happen, and people who don't want it to happen. There's both sides.
Oh,
both of those are happening very actively, and Quebec is sort of the battleground for this. But nationwide, I think people are having this conversation.
Yeah.
And
I think in the U.S. it's federally it's not legal.
I don't think it's a part of the law there. No. Not that I'm aware of, at least.
Yeah.
But one of the things that Atul Gawande is this amazing writer and doctor from Boston. We've talked about him before on the pod, and he wrote this book called Being Mortal, which I know we've read. And in that book, he outlines sort of how death and dying has changed over the past century. We went from having most people live pretty healthily until they eventually get struck by infection, illness, some kind of an injury that quickly ends their life within a span of weeks to months. Now, the way we're aging is, you continue on this slow, you continue to be healthy until, you hit your 70s, 80s, and then there's a long tail in there when you're not perfectly healthy, you're not perfectly sick, and yet you continue to be alive. And there's this long tail end. So death and dying has changed. It's gone from being an event to a process.
And it's your quality of life is slowly withering away.
Yeah.
right? I think you referenced a graph.
That's right. It's basically like that. It's you continue straight for a while, and then it's like a nosedive down,
Yeah.
or it's like a slow decrease until your quality of life gets really really bad right before death. And that's what I think this legislation is trying to avoid. It's allowing people who are chronically ill, who don't see a way out, and who are in a lot of pain, to end their life on their own terms. That's something that people can have a lot of opinions on. I don't know if I do, but the other thing around that is a lot of people just haven't had that conversation. Whether that's having that conversation with your friends, family, parents.
Yeah. I don't think I've ever had a casual conversation about medical assistance and dying, which
it's not an easy conversation to have. But one of the things that Dr. Gawande recommends in the book is the most important conversation you might ever have is if you've got an older person in your family who is probably more likely to die before you. Sit them down and have that conversation with them, and it can be a two-way conversation because tomorrow's not promised. But one of the things that he recommends is have a two-way conversation about not medical assistance in dying specifically, but advance directives. Advance directives refer to sort of the decisions to be made near the end of life. It's it's the typical pull the plug conversation.
Yeah.
It's not an easy one to have, and I think it's the hardest conversation I've ever had in my life.
You had one?
I sat my parents down and I said, hey, listen, I just read this book and I think this is something we need to talk about because I don't want to make sure that I respect their views on how they want to be treated. God forbid if we were to end up in a situation like that. And I made sure that I was clear about what I would want in a situation like that. It's not an easy conversation to have.
Yeah.
A lot of tears there.
I can't imagine. How old were you when you had that?
This was just not that long ago, like a year or two ago.
Damn.
But I read that book and, I realized just the importance of this. And maybe I'm not explaining this to the best of my ability, but when you're in that position where, God forbid, you have a family member who's ended up in a position where they can't communicate, they can't speak, but their body is still functioning to a certain degree. You have to decide at some point, along with the care team, what the next stage, or what the next decisions. You have to make some decisions there, some really hard decisions that, are challenging to say the least. But it makes it a lot easier when you know what the other person expects or would want to have happen.
Yeah.
So there are stages. I know we study brain dysfunction. There are stages of different brain dysfunction where, there's a chance that someone might be able to recover fully, but maybe lose motor control of certain levels. There are stages where someone has little to no chance of ever regaining full consciousness. There are stages where people might remain on ventilators or a sort of life support of some sort for the rest of their lives. We've spoke about people in vegetative states as well.
Yeah.
And there's a really interesting study from Western that I think we spoke about. Do you remember the fMRI study from Dr. Was it
Adrian Owen?
Dr. Adrian Owen. Do you want to talk about that?
Yeah. It was like an example of a research study that had a major societal impact on medicine in old age. And basically what happened was that initially people who were so there's this like kind of state called the vegetative state where how exactly what did it work again? It was called something like awareness without
something like awareness without consciousness. Basically, we assumed that these people could still maybe sense things, but they couldn't really perceive it or understand it, or they didn't have any sort of higher level cognitive function.
It was basically thought they couldn't move at all.
Basically, like people in a coma.
Yeah, people. Yeah, they thought they were in a coma. They had their eyes open though, and but what they found was that some of these people, through various ways, they found that some of these people could actually, they could respond to sensory information. Yeah. They could understand what's going on.
You could ask them questions. They could say yes or no using visualization.
Yeah, exactly. And that completely changed the way that we thought about how we should care for these people. And initially people didn't come visit them. Their family members didn't come visit them. So they were kind of devoid of any sensory stimulus and sensory input because no one would ever talk to them. And but that study changed it, and now people actually come and talk to their family members in a vegetative state. And
so that sort of leads back into like why it's so important to like have that conversation. Like, what if there is a chance that you might be able to consciously perceive stuff? Would you want to stay, be kept alive by machines? Is that something you would want for yourself? That's a really tough conversation to have, and it's a very personal decision to make. What makes that decision easier is if someone else doesn't have to make it for you when you can't communicate. Yeah. That's why it's so important to have that conversation, regardless of what age you are. Yeah. But maybe not if you're a kid. I think that's too heavy of a thing to talk about. I think I was mature enough when I had that conversation, and maybe it's a recurring conversation because stuff changes, people's preferences change depending on life circumstances and their level of maturity.
Yeah, but that's insane that you were able to do that. That's I think it's insane in a good way. That's.
I wouldn't say it was like an act of courage or anything. It was just that this text inspired me to do this because I saw just how in the book he outlines some cases where in emergency rooms people are making these decisions for their family members or friends, and it is quite literally just gut-wrenching to think that you would have to make this decision. And that's why like being on the same page, I'm a big proponent for open communication, and that's why being on the same page with other people, especially people that you are sort of the next of kin for, is really, really important.
Yeah.
I would encourage you, if you have the capacity, to talk to the people who are close to you about this.
Yeah. I think I think for me, I haven't even thought of my parents in that way.
I know. It's not easy.
Yeah. Even my grandparents I have.
Mm-hmm.
I think in at least my culture, it's something that you kind of just accept.
Mm-hmm.
No one really ever openly talks about it.
I think every culture, talking about death is perhaps the hardest thing.
Yeah.
It's talking in general, let's just say is pretty hard. Yeah. I read somewhere like the biggest, I think people's top 2 fears, like the second most feared thing in life is death, and the most feared thing in life is public speaking, which means that at a funeral people would rather be in the casket than giving the eulogy. So you're talking about death, you're just combining it into the most scary things in life together. So it's not easy, and I don't think it's a conversation to be had lightly.
Yeah.
But certainly, there's a lot of merit to doing it.
So how do you even go about, what do you ask?
I would refer you to the book, because I think it outlines that conversation really well. But from what I recall, I can tell you that there's no easy way to start that conversation. But once you've gotten the ball rolling, the question you're trying to get to is to what extent would you like care at the end of your life?
Yeah.
Let's say you and I were having this conversation for real. We would be talking about, if, God forbid, you were to end up in a situation where your brain has a very small chance of recovering to full capacity. Would you want to continue to be on life support for as long as needed for your brain to recover? If there's let's say, less than 20% chance of recovery at all. Is that something you would continue? And the other thing is, there's a lot of pain involved in this process. We don't know exactly because every situation is unique, but presumably there's quite a bit of pain involved if you're trying to keep someone alive. Running a code on someone, which is when you bring them back to life if their heart stops, or rather you continue life if someone has has a cardiac event of some sort. That is really, really tough on the body, especially an older body. There's broken ribs. There's a lot of stuff involved that you see when you're on the other side of the table, looking at patients at the end of their life.
Is it worth it?
Is it worth it to continue? That's sort of the big question. But then again, there's a lot of other issues there a lot of smaller stuff that you need to talk about besides just life and the end of life care. There's also pain medication, stuff like that comes with a whole host of side effects.
Yeah.
How much of that would you like? Really, you're just trying to set yourself up for making the best decisions possible should a situation arise that you hope to God doesn't happen. And one of the things that I was really surprised to learn was astronauts, they have this whole simulation of what would happen if they were to die. It was the Canadian astronaut, the guy with the stash. Chris Hadfield. Yeah. He was talking about this so candidly on his masterclass. He was talking about how they run a full simulation of, let's say, Chris Hadfield has died on the International Space Station and doing a spacewalk or something.
Yeah.
And he talks about how they walk through the entire procedure, just like they have contingency plans for failure to launch, failure to dock at the International Space Station, stuff like that. They have contingency plans for people's lives. Let's say Chris Hadfield, unfortunately, doing a spacewalk, dies aboard the International Space Station. There's an entire protocol that they have and that they practice for how that will be communicated to his wife, how that will be communicated to NASA back in Houston, how that will be communicated to the public, using media. They can use a public radio channel to communicate that from the International Space Station down to Houston, because that's radio signals that anyone can pick up on. That's if they go through the hassle to run that entire simulation. And Chris Hadfield, to his credit, invited his wife and kids, I think at least his wife, when they were running the simulation, because he wanted her to see, just in case this were to happen, how those things would play out, how that, how the news would be spread, all of that. And again, these are things that we really hope don't happen, but having those contingency plans is just so important.
Yeah.
I don't think we were going here today on the pod, but I'm glad we got to this point.
Yeah. No, but I think it's great. Yeah, I think it's great we talked about it, because these are things that I've never even thought about doing, because I don't know, death feels so far away.
Until it doesn't. Yeah. It's certainly not a comfortable conversation to have, but just your openness to having it, that's really important.
Yeah. And I'm going to be 100% honest, I don't know how open I am to have that with my parents.
That's okay. Take your time with it, and no pressure from me.
No, of course. It's just,
but I would recommend the book. Check it out, and if you do feel like you need to have that conversation.
Me the same way.
Yeah, I certainly I'm just another human dude. I obviously had the same struggle, but I'm really glad I brought it up, because after it was over and all the tears were out of the way, it felt like we'd worked through something that was really important.
Yeah.
It's a challenge, but it's a very, very important one. Yeah. Now that we've had a really heavy conversation about death,
now let's get into
the meat of the matter.
Yes, the meat of the matter.
Now, as I understand it,
yeah,
you are more Hindu than I am, where you just do not generally eat beef.
No. I don't. It's not that I don't eat beef because of religious reasons. I don't eat it because of habit. I'm pretty.
It's not something you were raised with.
No. I think I've had beef once, and then one time I had beef was I tried a piece of steak from my friend, actually at Cactus Club.
Okay.
Yeah.
See, I was raised in Texas, so steak is just it's the go-to.
Do your parents eat it?
What's that?
Do your parents eat it?
My dad eats it. My mom's a vegetarian, but my dad he'll partake, and my brother as well. But steak's very much a big part of my ideal meal.
Yeah.
If I had to pick a last meal, it's got. I know we're going back to death. We're not. But I do love a good steak. Where are we headed today?
We're headed to have my first steak, and at the Cactus Club down the road.
Awesome.
Yeah, it's. I haven't been to Cactus Club in a while. I haven't eaten out in a while, so I'm excited. And I haven't eaten a steak ever, so I'm excited.
I'm excited for you. I think you're gonna. I hope you enjoy it. I'm more chewy than you would think. Just saying.
Yeah. I've had it once, and it was definitely more chewy than I think. Is that something you'd say is bad?
No, I think I've grown to love it. I have like a fixed order that I get at Cactus. It's like a steak free. Got to get a 12 ounce because I love my protein.
Yeah.
And then get like medium rare.
Yeah.
Yeah, it's like the perfect level of chewy.
Oh,
and
medium
cooked for
rare.
me. Yeah, I mean,
I think I'm gonna get medium. I'm a medium man
if I'm worried
myself.
if I'm worried about the steakhouse, if I don't trust them, I'll go like a medium. But Cactus Clubs, you can usually trust to go a medium rare.
I just don't want it too chewy.
Okay, fine. That's chill. That's cool. Let's go get some steaks.
Yeah. So let's get steaks. Yeah. I'm excited. I'm predicting it to be not. I think I won't. Okay. On the first try, I don't think I'll like it as much as chicken. I'm gonna be honest.
Okay.
Yeah.
All right, man.
Yeah.
All right. You know what? Let's. I think you're gonna have a change of heart. I don't know.
Yeah, I think it's just because it's something my body has never had before.
Okay.
So my body might try to reject it.
Okay. Okay.
Especially my mind.
I'm just excited to see you try it.
I'm excited to try.
If you can't finish it, I'm just
I've been watching a lot
I
of
haven't had lunch.
I've been watching a lot of steak cooking videos,
ASMR videos.
especially ASMR videos.
Yeah.
On the bus.
You're just like sitting there on the 99B line, like going through TikToks of like ASMR steaks.
Yeah, that's exactly what it was. Yeah.
Yeah. That's sick. All right, let's get out of here. Let's get some
Okay.
steaks.
Okay. How do we get there?
All right, Addie's first steak taste. How we feeling?
Okay, 8 out of 10.
8 out of 10? Mm-hmm. All right. That's pretty good.